Well, thank you, everybody. Thank you for the society for allowing us to have this opportunity to talk about our robotic platform. Definitely, we appreciate J&J Ethicon leadership to give us the opportunity to shine light on a great upgrades and updates and innovation that Monarch has brought to the table. I have a dear friend of mine, my colleague Dr. Valor, with me. He's going to share a little bit about his experience and how did he grow his robotic program down in beautiful Florida. I'll go over some slides about my program in Grand Rapids, Michigan. And if you start having questions, please feel free to send them to the chat, and we will address those time allowing. And without further ado, let's go to the next one, please. So both Dr. Valor and I, we are consultants for Ethicon J&J, and you can see that this is not a CME presentation. Nonetheless, you're going to see real work done with a robot in our programs. Next. So the first question that I get asked a lot, and I'm sure Dr. Valor also, is what's Quest? Quest is the latest, most innovative, most powerful upgrade to any robotic platform in the world. It has integrated so many updates and upgrades that now it's easier than ever to get to the most difficult lesions anywhere in the lung. Therefore, we are pleased to announce that we have confirmed in our programs everything that you have in these slides. We have a better processor, NVIDIA, more than 200–300% faster. We have more reliance on the tracheobronchial trees from the CAT scans. We are integrating Monarch with pretty much every cone beam out there, and it's really good for accuracy and precision. Now we finally, as doctors, have a robotic platform that can allow you to see uninterrupted, combine, and integrate with any cone beam CT scanner in the market in the US. And I'm pleased to say that it's more seamless than ever, and we feel more empowered than ever. And we're going to put a little bit of more information with real experiences. Next paragraph, please, or next slide. And what is it? First of all, we only have an hour, so we could be talking about the benefits of using Monarch for hours on end. We trust our patients' care. We truly believe that all the features such as smart navigation with all the algorithms and artificial intelligence and recognition of optical and kinetic data, this is really, really good. This is really, really good. We can get way smoother than ever before with way more accuracy, knowing that every turn that we make is backed up by great piece of technology. Advanced image integration. 5 years ago, it was a question whether cone beam CT was a thing for pulmonologists. And now I think that is undisputed. I cannot come across a single LinkedIn post that says you got to get a cone beam CT scanner. So the debate is over. Let's see if we can put other debates on robotics to sleep after this presentation. We can reach farther. We have absolutely pinpoint precision whenever we are able to do micro adjustments on the tip of our scopes. And the most beautiful thing that I will continue saying this until I retire from robotic bronchoscopy is seeing is everything. I like to see what I'm doing. And what better than having the most powerful robotic platform with uninterrupted vision? That's what I really call a true robotic platform. And we can go on the next slide. Dr. Valor, he's my friend, and he actually got a Quest before me, and I learned from him. So there you go. Take it away, Dr. Valor. I'm going to mute myself.
Thank you, Gus, and thank you to J&J for giving us this opportunity to present this symposium. This is very exciting. These are very exciting times, and I'm looking forward to presenting my experience. Go ahead to the next slide. So I work at Baptist Hospital in Miami. It's a relatively large healthcare system. To date, I've done about 250 cases using the robot, and about 30 with the integration. I've been a user of the Monarch since 2022, and I've lived through all the technological advances that we've been seeing to date. Next slide, please. So this is what I think is one of the points that I'm most interested in bringing to the seminar today. I started practicing in 1992. Yes, I'm an old guy. So at the time that I graduated from fellowship, interventional pulmonology did not exist. There was no such thing as interventional pulmonology. So I was not trained in any of the advanced technologies in robotics. So I came to practice to Miami in a community setting in 1992. And basically what I had at my disposal was regular fiber optic bronchoscopy. I did innovate the video aspect of it, which at that time was kind of innovative. And finally, in 2012, I started using Varan, and that was, as you all know, one of the earliest forms of navigational bronchoscopy. My institution set out on an endeavor to open a cancer center, and having always been interested in the aspects of interventional pulmonology and advanced bronchoscopy, I felt this was my opportunity, and I started training in advanced bronchoscopy procedures and so forth, so that by the time our cancer center had opened, I was proficient at EBUS and cryo, PDT, APC. I even did bronchial thermoplasty. So I had these procedures and these services available to the cancer center at the time they opened. Now in 2022, everything changed. The world changed completely, and finally we started doing robotic bronchoscopy, and I introduced the MONARCH platform to our institution. And finally, earlier this year, we went into the Quest with cone beam CT integration. Next slide. So this is a typical workflow for my cases. Essentially, we get the CTs done either the same day or the day before. We do the planning, as you all know, at the workstation, and then bring that planned procedure over to the tower. And from there, we get going and let the magic happen. Next slide. So there's two cases that I want to share with you all tonight. The first case is a real challenge. I want you all to know that the day that Dr. Cumbo was kind enough to join me in Miami for my case, I actually had 3 cases scheduled that day, and the 2 of those cases were canceled or rescheduled for whatever reason. We were not able to do it. So the one I ended up doing was the toughest one of all. If you remember, Gus, that was a very difficult case, and I'll present that to you all now. It was a 68-year-old gentleman, a patient that had a 30-pack year history of smoking, greater than 30-pack, and had a previous history of lung cancer with a left upper lobectomy for stage 1B squamous cell carcinoma 7 years earlier. He did not receive any adjuvant treatments at the time, continued to smoke, and he was found to have an abnormal CT of the chest, for which reason was referred to me. It also came to me with a PET scan, which showed increased FDG activity in that lesion. He had no weight loss, no environmental or occupational exposures. Next slide, please. So the lesion, as you can see there, was 9 millimeters in size. It was very hot on the PET CT, and this was the case that I was left to show Dr. Cumbo how wonderful our new Quest system was. And I don't think we disappointed you, did we, Gus? Okay, so we planned the case, and we went on to navigate to the lesion. Next slide, please. As you can see here, particularly in the slide on the right, you can see that I was able to deploy a needle to the vicinity of the lesion, right adjacent to it. We made some adjustments and some fine tuning, and I was able to direct the tip of the bronchoscope a little bit closer to where the lesion was, and I was still at the very least about 3.5 to 4 centimeters away. So because I was at this distance, Dr. Cumbo suggested we use a gen cut needle. And by the way, this was the first time that I used one of these needles. And for those of you that are not familiar with it, it's a needle that essentially has a cutting on the shaft of the device itself, and it requires thrusting movement and suction simultaneously. and it's very good for lesions that are eccentric and you're not able to impel the lesion directly. Next slide. So as this is a video of the navigation to where the lesion was. We did have to do a little bit of off-roading, as Dr. Cumbo referred to it. This patient had very severe and advanced emphysema, but fortunately everything went well with no adverse events here. Go ahead to the next slide. And we were able to get pathology that was consistent with an adenocarcinoma, and the patient was then eventually treated with a stereotactic body radiation therapy. So the learning point here is that this was a very small lesion by anybody's criteria, very peripheral. I was not able to get very close to the lesion, and despite this, because of the technology and because of the advantage of Quest integration, I was able to arrive at the lesion and establish the diagnosis. Next slide, please. So the next slide is a pretty straightforward one. The next case, this was a 72-year-old gentleman, 40-pack year history of smoking with an established diagnosis of COPD. This is a patient that I've been seeing in my practice for a number of years and pleading with him every time I see him to quit smoking. He has continued to smoke, so he's an active smoker. Every year, CT of the chest and PFTs. PFTs show a moderate obstructive impairment, and really no symptoms, no new symptoms, no weight loss, no environmental or occupational exposures. And as you can see there, there's a pretty large lesion in the right upper lobe. Next slide. So basically a video of the navigation to the lesion. Again, this was pretty straightforward. I was able to visualize the lesion on radial EBUS, and the integration was very helpful at helping me point the tip of our bronchoscope directly to the lesion after some corrections that were made. Next slide. Here we go. This is the actual video of the navigation process. Pretty straightforward case. Really nothing extraordinary about this case, except for what I'm going to say at the end. Did some fine tuning there. And there we go. We pointed the tip of our instrument straight at there, and we were able. All right, next slide. So a bit of a surprise, this was a benign inflammatory and infectious process. The patient was treated with antibiotics. So why did I present this case? The reason I presented this case was because the first one I presented was a malignancy. The second one was not a malignancy, and many times, and this has been a frustration that I've had for some time now since I started doing robotic bronchoscopy, was that many times we get results from pathology and they report no tumor, non-diagnostic. So essentially, we think that we never got anything of any value, and we did a procedure for no good reason. But in fact, this case did show and does illustrate that sometimes there's lesions that are benign, and that's the beauty and the value of having this technology, that we know that we were in that lesion. We were able to show that our tool was within the lesion in several projections, and we are confident that we can treat this patient with antibiotics or anti-inflammatories, whatever applies, and comfortably continue to follow this process and not have to go to the next step as we had to do in the future and pursue more tissue and go with a percutaneous needle or an open biopsy or what have you. So that's the beauty of Quest integration in this case in particular. In the first case, it was a malignancy. In this case, I was convinced that this was a malignancy given the patient's history, the fact that the CT showed a mass, that it was FDG avid on PET, but yet it ended up being a benign process, and subsequent CTs that I've done on this patient after treatment with antibiotics have shown resolution of the lesion. Next slide. So the take-home message is that the addition of MONARCH, and particularly after the advent of the Quest integration, has really revolutionized my practice. I'm confident whenever I get a result from pathology that it's non-diagnostic. It is diagnostic. It did give me an answer, did tell me there was no malignancy, and I'm convinced, and I know that that biopsy was obtained from a good area. I know that my tool was within the lesion. I was able to reach a lesion that was in the periphery sometimes more central. And this obviously leads to earlier diagnosis of lung cancer, better treatment outcomes, better treatments overall, and better patient outcomes, and no more watch and wait. Next slide.
Thank you, Dr. Valor. There's so many comments that I have about your slides, and I think that it's important to know that the robot doesn't give you a diagnosis. The robot doesn't have a diagnostic yield associated. The robot gets you there, gets you next to it. There's so many other factors that go into a diagnostic yield. You have to wait, you got to follow up the quote unquote non-diagnostics. I feel very reassured. And this is not an academic discussion of what criteria, strict, this and that. That we can have a different conversation. What is the robot good for? Getting you there 100% of the time, over and over, this has been published. Getting a tuning lesion, now that we integrate images, you can reacquire the target and get rid of CT to body divergence. We have not only one technology, it's not just EM or just kinetic data or just optical recognition. These are all technologies, more than 3 combined, in order to give you the accuracy and the precision to sample a lesion. Diagnostic yield also have to do with location. I live in the Midwest. Obviously, I'm going to have a lot of history that is granulomatous inflammation. Does it mean that I'm less of a robotic bronchoscopy user because my quote-unquote diagnostic yield is 89 and not 92? So let's go and get to the next slide about how do we make this a game changer for the robotic community and aspirational platform for anybody that prides themselves on daring to venture in the periphery of the lung. We have more than 1,100 cases. We started in 2018. We were the first in Midwest. Shout out goes to Cream Manley, the OG of MONARCH, that he's in the East Side. And we're loyal to this. We're loyal to this platform because it works really well. I would never, ever have a second-class platform and neglect the fact that I have so much experience with MONARCH. We can get anywhere we want, and 100% of the time with image integration will get you next to the lesion, 100% of the time. So how many? Probably more than 60 on Quest. We launched not long ago, and we've seen that there's no difficult target to reach. There's some difficult targets to biopsy. There's different diagnoses to get to, but there's no impossible target to reach. That's one of the premises of MONARCH: reach, control, vision. Let's go to talk about, I started with Philips a long time ago, fixed system. When everybody said fixed system is the only thing to work, I said, well, what about mobile systems? I use Siemens Sios, I use OEC3D. The platform that I choose is OEC3D for a number of reasons. Quest is integrating with everything. Up and coming updates are going to make it the Swiss Army knife of robotic platforms. And I cannot think of any case that I would not go after with MONARCH. So my go-to is OEC 3D. Occasionally I use Siemens, occasionally I may use Philips, but this is what I work. This is my go-to. This is my top drawer. And I have the side bevel needle, which is what Dr. Valor was referring as a side cut. You just essentially rotor-root the airway. And if you see, and I have one case that we're going to see directly, that I navigate very far in the lung, and I can see what wall the radial probe is touching. So I don't make a decision to biopsy just based on radial ultrasound image. I see which wall has the extrinsic or the eccentric lesion or extrinsic component to it. So I am very reassured that when I'm at ultrasounding and I see an image compatible with the tumor outside of the airway, I know exactly where to put the needle. And the farther you get, the less that the lesions bleed and the less that the peripheral vision is compromised. So I'm glad to say that my first 2 or 3 needles are always without any blood, and eventually I forceps and I cryo, and obviously this gets bloody. But let's call things the way they are. Uninterrupted vision, to me, is everything. Next, cryoprobe, big debate about cryo, so I don't want to start there, and probably questions can be answered later. So we got FDA approval, and I've been very grateful about our involvement, the real users, the real community users that are making this platform better and better. So once we have Quest approval, I can tell you that our doctors are going after pretty much everything. So shout out for getting FDA approval this year. The platform is extremely robust. No more glitchiness. I mean, 2018 was trying times for all of us when we just developed robotic bronchoscopy. We still were using gaming controllers and going to Central American countries to prove a concept. Right now, almost a decade after, look at what we're talking about. NVIDIA processors and artificial intelligence and mapping to the millimeter, and the confidence that we have not only with the hardware, but also with the software is second to none. We have cases that we've done, the first 30 cases that I did, and another so many from Dr. Valor, and 100% tooling lesion. We can talk about diagnostic yield as an academic debate. The truth of the matter is the robot does 100% of what it should do all the time, getting you next to it and then sampling. Can we biopsy better? Of course that we can. The human component on diagnosis is everything. I don't think that any robot does everything on its own. You have to have the acumen, understanding 3D, and thinking about trajectory of the needles and what do I use. Well, there's so much that goes into robotic that simplifying that a robot is better, I'm not so sure that I ascribe to that. In my opinion, I believe I'm using the best platform. Let's talk about publications coming up. Obviously you have all the technologies that we were integrated. We were talking about electromagnetic sensing, field generation field. We have computer vision, optics, insertion data, kinetic data. So it's an oversimplifying saying that it's an EM-based platform. So how about if we just get a little bit more up to date with what's going on and all the developments from J&J Ethicon, and then we can have an educated debate on the comparisons between what can I use to service my patients the best. In Gateway, obviously we have access to all our videos a lot of times, and we can extract video and do education and quality. Where are my nodules? What are the areas that I struggle the most? Is it superior segment of lower lobes? Is it apical? So Gateway is an extremely powerful solution for the practicing physician that would like to pop the hood and see, how good am I? Let me review my 1-hour case and see why didn't I get the diagnosis? What did I do wrong? Absolutely at your fingertips with Gateway. So shout out goes to the Gateway team for every software augmentation that you do. Next. We grow, the value of a platform is quality plus outcomes over cost. So whenever you talk about the quality of the Monarch with Quest, the outcomes that we have that are second to none. Publications speak for themselves, by the way. And the cost, we see that our community, doctors in our area, doctors that have before sent to IR for a biopsy, they understand that we get to anywhere and we can diagnose and stage. There's no time lapse. They know that we use the best imaging technology to integrate to Monarch. So right now, it's easier than ever to get referrals and justify an investment, justify the capital investment, justify the tools and the anesthesia, the combine, because you can see my numbers growing by 30% per year. We are increasing so much. We have so much OR time, bronchoscopy suite time, second robot coming up. Next. All right, very simple. I am not a LinkedIn warrior. I'm not going to go publish my 6mm nodule that I got yesterday with cryoprobe. That if you want the platform to speak through the doctors, have the doctors publish data, and that's what we're doing. So 1 centimeter, garden variety, smoker. We didn't have an airway sign. You can see what I was trying to get to. Next. Okay, this is where I'm going to drink some water, and I'm going to show you how easy it is to do some case. Why is important vision? Vision is not everything on everybody. Sometimes you have an endobronchial lesion and you just take a couple of forceps and you're done. But I can very slowly take my time, allow everything to kind of settle, use all my, by the way, it's very intimidating to see so many screens, but it becomes second nature. How important is to see your radial probe where it goes? I don't want to do this blind. Why would I? Now that we know where we are and we want to integrate, we do click, click, enter, enter. We get a spin, and now we can see where the tumor is. I'm going to use the very powerful software solution that our friends in Ethicon have designed for us. I'm going to mark where the nodule is. I'm going to mark where the robotic scope tip is. And once they're lined up somehow, close enough, since I drove already to the target, I'm going to do micro adjustments to show where the tip of the scope is, to educate where is it going. Sometimes the scope goes up, sometimes it goes down. A trick that I use, I thread the radial probe, not in this case, but I thread the radial probe. So whenever you have the virtual reconstruction of the scope, you know what's distal, what's proximal, and what part of the airway has the signal. Once I acquire both the the nodule and the tip of the scope, we integrate, and CT2 body divergence gets rid of. So what appears to be farther, it's a little bit closer. That may have been the reason why we may have overshot, especially programs that don't have cone beam CT. That doesn't mean that the robot doesn't work with cone beam. This is for maybe a 7mm nodule that doesn't have an airway sign. You saw how by a pressing of a button, the nodule came a little closer to me, so I can be a little bit more shy on the throw of the instruments. 10 out of 10, no doubt about it. Next. Okay, so do I do every case that I do 2 or 3 spins, and do I position the patient? You know, what? Each case is different. I try to see with the robot all the way to the pleura. In every case, no. Some airways are 2 or 3 millimeters. I don't get in a petite 40-year-old female all the way to the pleura. So let's have a debate that is with common sense. The majority of the cases, I can go as far as the outer third. I don't get to the pleura on all of them, but I could if I wanted to. So do I see it? No. Next. Can I use radial probe in the general area? Yes, no. So you can keep on going and kind of adjusting. Now, image integration is everything for me. Since I don't see it I don't see it in real time, and I don't see it in radial, well, now it's time to roll up our sleeves. Now, let's do everything. Now, on this case, you see the radial probe coming out. That's what it is. And I can actually see oftentimes the radial probe touching the lesion to know when I'm going to throw anything. To the right, you can see the radial probe coming out. How beautiful is to see your tools going in and see in real time if there's bleeding or any problem. I love it. Next. So the choice of cone beam. Well, you have a cone beam in the hospital. If you don't have a cone beam in your hospital, there's a lot of companies that are willing to work with you to get you. You can go to see any of our MONARCH cases. You can touch base with your local rep or somebody within the company. You can contact Dr. Valor and I to come see our cases. We have open doors for anybody to come and see our cases. And the reason why I picked GE, I don't have anything negative to say about other, it's my preference. Why? First of all, bigger field of view. It just shows me more. I just can see much more. The image quality is better tissue discrimination. I can see ground glass nodules, whereas in some other platforms, I don't see it as well. There's segmentation, there's segmented fluoroscopy. Somebody told me you will never get all of these software augmentations on a mobile platform and you only use fixed system. Well, that's not true. As of a year ago, GE developed segmentation and augmented fluoroscopy, and it works really, really well. And there's more developments coming from GE, as for example, a virtual pathway to lesion, and we can talk more and more about benefits of cone beam. I don't dare to do robotics without cone beam. I never get easy cases of 3-centimeter masses that I go to the robot and find it. I don't see my clinic patients. They're sent to me. We're doing so much that I don't have time to see office patients. Next. All right, tooling lesion. First step, get in there, robot, 100%, good. Undoubtedly gets you within 1 centimeter of every lesion, unless there's no airway sign, and we're gonna have to get tinkers, and that's where cone beam integration comes to the rescue for us to throw 2-3 centimeters of a needle and get exactly where you want to be. But what is my experience with tooling lesion, and why is it so important, tooling lesion? Because that's the second step. You go there, now is the tool touching it? We're going to talk about lesioning tool later. Next slide, please. By the way, all of these are my cases. This is a case of Siemens Sios. You can see how different the image is. It's still a very good image. You can see that you have the 3 planes, coronal, axial, and sagittal. You can see that I was biopsying a carcinoid. You can see how the needle kind of makes a weird bend, and there's a little bit of blood, and 2 or 3 passes after, that's going to be obscured. That's what's so important to have a very, very powerful robotic bronchoscopy platform such as MONARCH to know where you are, even though you may not see anymore in cone beam. Next. Okay, so this was a very simple case. First pass, squamous cell, EVIS, sent to resection, patient doing fine. Next. All right, so we are 4:30. I'm going to make a pause here. Dr. Valor, you can unmute and maybe add a little bit of anything before I go into my data, and we can talk a little bit more about anything so far.
No, not really. I don't really have much to add, Gus. I think your cases are pretty compelling.
Thank you. Very quick. This is 2018, MONARCH. This is when MONARCH was the only bronchoscopy platform. And we use Conbeam CT. And even though this is 7 years old, we still publish all our data, and we're very transparent about what we do. So back then, whenever we use MONARCH without integration, and it took a couple of years to get it published, by the way. So we did 20 cases, nodules, 22 millimeter. Our sensitivity for malignancy, meaning how likely is I'm going to diagnose cancer of all the cancer cases, we were at 86.6%. And we use 2.4 Conbeam CT. Sometimes we spin before, sometimes we spin after, but we didn't have integration. So it was very much so a way to do things when we didn't have integration in any other platform, or it wasn't even in the horizon. We didn't see any interference. So for those that are somewhat hesitant to consider an electromagnetic navigation featuring platform, if you want to even neglect every other piece of technology that makes MONARCH the most robust platform in the market, we didn't see any interference. Do you have to move the Conbeam out of the way? Of course you do. Is that a problem? Well, it is if you cannot spare 5 seconds, but I would prefer to spare 5 seconds times 3 times and have the best platform on working on the challenging cases than leave things as they are and hopefully I get a diagnosis. So we've been pushing and pushing and pushing as a community, and we're getting excellent results. And we didn't see any complications. We didn't see any complications on that very limited trial. Next, but let's go fast forward in 7 years. We were happy then. This is a little bit of more of the data. You can go to ABIP journal, the Journal of Bronchology and Interventional Pulmonary. You can read, everything is there. Next. Okay, now this is the AIM trial, the trial that we're doing with Dr. Valor. We're combining both our data. And my data is the following. We did retrospectively with the first 30 cases that we do with Quest. So we were gathering data prospectively of what's going on in the procedure, and then we analyze prospectively. More so the IRB and things like that of a prospective trial versus retrospective. And we were not claiming any more than this works really well, and this is the standard of care based on our robotic platform. So 30 patients, we were doing 2 centimeter. Again, do you want to do a trial with 7 millimeter nodules? Sure. I didn't. I wanted to see how well it worked on 2 centimeter lesions. And we integrated with OEC3D, 2 lesion in every case. No doubt, whether it's centered, off center, whatever it is. We got 2 lesion and we got samples. Complication on the same patient, both pneumothorax and bleeding. So I may have gotten a little aggressive at biopsy. Interesting enough, this case was diagnostic. So I don't remember if I used cryo, it's irrelevant. And in this outcome, what that means is, what do we know at 48 hours after the procedure? That's what we get. So half of them were cancer. So let's start with at least a quote unquote diagnostic yield of 50 to 60%. 2 out of 30 were infectious, what Dr. Valor was saying. We have the image of the tooling lesion. We culture a bacteria. We treat it with antibiotics. I don't have 3 or 6 months to tell you what it was. I will follow up with paper with Dr. Valor when we can track down this 30, but this is what we have so far to show you that this works best than anything. Non-malignant, meaning this is the mashup of things that it can be granulomatous inflammation, atypical cells, whatever, radiation fibrosis. This is not an academic debate. What I'm saying is that 9 out of 30 with tooling lesion were non-malignant, a benign tissue, 3 out of 30. We're gonna publish this, and we're gonna have a nice chart with every finding, and feel free to reach out if you wanna learn more. Next. Last but not least, the robot procedure from insertion to getting the scope out was roughly 37 minutes. The average CT to body diversion was 1 centimeter. At the basis, it was 2 to 3 centimeters. At the apex, it's almost none. So this is an average. Now, are we going to analyze the CT to body divergence per area? We could, we may, I don't know. We'll see how we feel. We never saw anything shrinking of these patients. We saw either stable or larger. It's important for those that do Conbeam and do spin before to report to the community. There's somewhere in there 7 to 10% of shrinking lesions that probably you don't want to biopsy. I didn't see it. I'm not going to comment on it. Bronchosign, 8 out of 30. That's why we use Quest on these patients. Otherwise, I don't include patients that had an endobronchial lesion. I'm including the Quest patients, the ones that for some reason I wasn't getting to, or I thought that it was going to have trouble. Very peripheral. Quest to the rescue. The characteristics, most of them are solid. Some of them were not. And Rebus, you can see that there was mostly eccentric and no signal in the Bronchosign. 7 out of the 8 were concentric, 1 was eccentric. Next. They were nearby airways though, but not Bronchosign. So my confidence is very, very high. I look back and say for the past 7 years, I've been using this platform and I never trusted this more than now, ever. I can go after smaller lesions. I'm sure Dr. Valor also feels very emboldened now that he can get anywhere, see uninterruptedly, integrate with COMBEAM and sample safely. I think that the third step is going to be lesioning tool, but this is not within what we're talking about. We're talking about the best platform with the best upgrade of 2025. So jump in. We've been doing pleural-based. There's a lot of patients that tumor boards say, well, we can do IR if it's possibly PET and EVAS. No, robot first, or most of them. That translates into a lot of referrals. Radiation oncology saying, hey, this nodule doesn't look good. We go there, we integrate, we get a needle, we see that we're going in COMBEAM where we're going, and now it's radiation fibrosis. Do we believe that? Why not? The tool was in the lesion. So we can optimize case selection for different type of cases with MONARCH and integration and Quest. We can do a very short 10-minute case, or we can do a 1-hour case. We don't leave the room until we have a reassurance that the tool was in the lesion. Average time, 37.5 minutes. And some lesions that could be resolving, we could definitely go after, and we can confirm with COMBEAM CT if we go after lesions that could be resolving. I think that most of the doctors in the line know about some lesions that may have shrunk on follow-up CAT scan, and then 3 months later it start growing again. So COMBEAM CT is a very good adjunct, and I would say that it's better than ever I've seen, better than anything I've seen in the market. Next. So last but not least, this is my own quote, and you can read it. I think that having integration of advanced imaging on Quest, artificial intelligent driving with a very powerful processor, better tracheobronchial trees, better segmentation, the performance is very reliable. We are precise and accurate. So this is not a conversation on how to do bronchoscopy. Bronchoscopy is simpler than ever. It's about how many cases we have to do, how many cases do we have to do, what are the support system, and the robot is the centerpiece of a program. The diagnostic yields are program diagnostic yields, they are not robot diagnostic yields. So I am unsure why we're still having this conversation in the community of diagnostic yields of robot. These are diagnostic yields of programs. So with MONARCH, better than ever. Next. All right, so it's 4:40. I think that we may have a little bit of time, a little bit of Q&A. Definitely, I would love to hear from Dr. Valor, maybe some closing remarks before we open a Q&A session. I have a couple of questions for Dr. Valor. If anybody has questions, please feel free to type in the chat. Otherwise, I have a question for you, Dr. Valor, whenever you're ready with your closing remarks.
Well, thank you, Gus, for your presentation. That was actually very nice. No doubt that the MONARCH Quest has elevated bronchoscopy to a different level. We are able now to do bronchoscopy with great confidence and navigate to lesions that we could not have ever dreamt to even tackle some time ago. I think the extra confidence that we acquire from being able to demonstrate that our tool and lesion, and whenever we get reports that there's no malignancy, as often occurs in my institution, and that's not dismissed as a non-diagnostic procedure, but rather as a diagnostic procedure, but no cancer. And that has changed my practice completely. The additional confidence of knowing that we got the appropriate tissue, and that we had real-time vision, and we know exactly where we're at. So it's a total game changer.
The one thing that I wanted to add, Dr. Valor, that not only is a game changer, but one final comment, and this is something that is important for me. For having worked with Ethicon J&J for the past 7 years and seeing how strong they're coming with innovation, seeing how much support the companies have, how much they have invested in Monarch, having seen the landscape and what the future holds with upcoming innovation, to me, it has always been a safe bet. I trust the product, I trust the company, the longevity that they have in the market, the many innovations that they're bringing to the table. So I am very, very, very pleased. And when I look at my administrators and I said we should get a second Monarch, I know that there's a company you can trust, and there's a company that the longevity that we'll have with robot and has been establishing is second to none. So I trust, and this is about trust, about trusting the platform, about trusting the company, about trusting the future direction. And my patients, when they look up online and see what we do and where we are, they feel really reassured about going to sleep and wake up, hopefully knowing what's going on. If you don't have anything else, Dr. Valor, we can open maybe for some questions, and maybe in 5-10 minutes we can wrap up and everybody can go back to their families, to their jobs. And please, Emily, do you have any questions, or maybe Bridget?
I have one additional comment, Gus, and that's that I'd like to encourage those pulmonologists that are pursuing this, that are from my generation, that really didn't have formal training in interventional and advanced bronchoscopy as your generation did. That this is something that's perfectly doable. This is something that you can integrate into your practice very easily, and that J&J has been, throughout this journey that I've been through, has been extremely supportive. My representatives and account managers, district managers, everybody, they've been nothing but extremely helpful, and they've been there every step of the way. And this is something that if you're thinking of pursuing this and starting a advanced robotic bronchoscopy, this is the way to go.
And to add to that, Dr. Valor, and again, we talk so much about Quest, and we barely scratched the surface of what it can do. I seriously welcome you to see a case. Some of the current robotic bronchoscopy users in the country, they came to my shop when we started back in 2018, not believing what the platform was able to do. And life has shepherded the community not only to think about robotic bronchoscopy as the go-to for a lot of things, but also in education programs. We have a fellowship, we have 4 fellows per year. From the first day that they step foot in bronchoscopy, I train them on Monarch. They are the new generation that they can, most of them, they play video games and this hand-eye coordination, and to have that, to me, to be able to use a gamer-like controller and do that, and it really takes me a couple of minutes to get to the target and then biopsy myself, and the fellows love that. So I would say between 10 and 20 cases you understand. More than 20 to maybe 30, you're good. It takes a few hundred to be an expert, to be a black belt. I invite you to reach out to our associates in Monarch and learn about the educational opportunities, whether we are going to stream cases live through Proximie. These are not heavily edited with music in the background. Go in LinkedIn and check my 20 seconds of a 7mm nodule. This is, come see the whole hour. See the integration of the cone beam, seeing how smooth the driving is, see how much support there's from the company in every case, seeing how the patient recovers. So we have virtual sessions. Not a virtual session person, talk to anybody within J&J Ethicon, go see Valor if you would like to take a look at beautiful place in Florida where he has great facilities and great staff. I was humbled to see how well it works in a hospital that I didn't know before. And definitely come check me out in beautiful, warm Grand Rapids, Michigan is always an option. But the company wants to learn about you, wants to learn about what is that you're setting to do, how can we help you to set up programs, how do we grow volumes, how do we integrate with the cone beam. These are people that are genuinely interested in developing a program for you to help patients. That's the mission that I feel that it resonates, and I'm training all my fellows in robotic. They have roughly 50 plus cases at the end of their training. So we're going to see a big influx into robotic in a lot of practices. So We're changing one generation at a time, Dr. Valor. So we may be old school, but that doesn't mean that we're done. Okay, questions. I know that everybody's starting to look at watches, and this has been a unique opportunity to share with us a real world community program experience. And if we can do it, you can do it.
Yes,
Anybody?
thank you. Yep, thank you both. We do have a few questions coming in, so we'll start with this one. What advice would you give to the physicians who are considering adopting MONARCH QUEST?
I will give the right of way to Dr. Valor. He has been first. So what motivated? What motivated me to go with the MONARCH QUEST was the data that was presented to me. I was put in charge of acquiring or advancing our bronchoscopy program at the hospital, and I had the opportunity to try different platforms. And when I saw the function and the way that the MONARCH was worked and the features, and to me it was a no-brainer. So that's basically what pushed me to go in that direction.
And Dr. Valor, I cannot agree more with you. To me, it's when I wake up and I say, what's the best out there? What's the best tool, the best platform? What's the best patient to do? And to me, is the same as my car or my phone. It's a value proposition. What's the value proposition? The value is quality plus outcomes over cost. And we're not here to talk about cost. We're here to talk about patients. We can talk about cost. We're going to take it offline. What's the quality of MONARCH? What's the quality of MONARCH? Well, how much it improved? I would say that improved to redefine excellence in robotic platforms. That's where it is. The quality, no malfunctioning, no glitchiness, no CT2 body divergence that cannot get rid of. So what's the argument? What is the argument that we're having among the quality of MONARCH? MONARCH is leveraging so many technologies in one that with integration makes us lethal. We can go and hunt anything, anywhere in the lung. Obviously not in your first 20 cases, but maybe on your 200 and 300, you're gonna feel emboldened and say, in the fissure, I got it. And worst case scenario, put a chest tube. How many chest tubes does IR put with TTNA? That was almost for sure. So quality, really, really good quality, combining a lot of technologies, and the company has been around for so long and it's going nowhere. What's coming, it's gonna be amazing. Outcomes, that's the second component of the value of MONARCH. Outcomes are second to none. Outcomes are second to none. How are we missing? You saw 100% to lesion. We may not have a final diagnosis. That's understandable with the incidence of fungal disease and maybe a sampling error, but comparing robotic platforms on diagnostic yield, you're missing the human factor. The human factor is the most important factor in success for a procedure. If you're not a good robotic bronchoscopy user because you've never done it, you can grab any scope and it's gonna be the same. It's not gonna be the same if you're an expert on MONARCH. So the outcomes that I have with MONARCH, I cannot replicate with any other. I don't want to go out there and see how else can I do different things. I'm learning in every case. And I have a masterpiece piece of equipment in my bronchoscopy suite. Cost, we can talk about it offline. Definitely it's an inflammatory topic these days with all the financial. But to me, the reason why I would, and I will do it again with another MONARCH, is a true value proposition second to none in the space, and in my eyes, the leader of the market. Any other questions, Emma?
Yes, yep, a few more are coming in. So this is a comment and a question. Thank you for sharing your year-over-year RAB volumes. As volume rose, which parts of your training approach made the greatest difference? And what guidance would you offer to sites that are ramping up?
What was the first question about the approach?
Yeah, as volume rose, which parts of your training approach made the greatest difference?
Training approach, training meaning the training provided by the company, training of the training that I had. I can answer that question very simply. It's very instinctive to do robotic bronchoscopy. It's like the musician that is playing on stage after many years and he just clicks that there's something he can do with the guitar that is amazing. And that's why you go from great to memorable. What I find out after a few hundred cases is that I found that instinct to go after anything. And there's no better motivator than doing the right thing for the patient. And I would biopsy every patient the same way I would biopsy a brother or my father. So you're gonna get out of the procedure as much as you put in. Do you study the CAT scan? Do you know where you're going? Do you establish Your landmarks, have you taken enough time to find it? Do you know what tools to select? The robot is an instrument, but we are the ones. So I would say 20 cases to be good, 40 to 50 to feel emboldened. After a couple of hundred, you're a superhero in the chest. Dr. Valor?
I agree. I think the 20 count of 20 to start feeling proficient and comfortable is spot on. And I think a couple hundred really, as you said earlier, makes you the black belt in it. Pretty much.
Well, and something I love about what you say, Dr. Valor, and we're going to do a couple of more questions, and there goes our night. I could talk about this for so long, maybe half an hour more, but then we're going to have to wrap up. You know, one of the reasons why I partnered with J&J Ethicon back then, Oris, in 2018, was that they're fully committed to skin to skin, from the time of presentation to time of diagnosis to providing them with surgical options, with so many things. So I think that whenever I take a look at the robot, it's really a true manifestation of the spirit of Ethicon J&J, is getting the best platform, from shaking hands with the patient, never knowing, to hopefully looking at them and say you're cancer free. So for that reason, I'm proud of my tool. What are the questions?
Yep, here's another one. It seems like this is a huge, oh, another one just came in. Hold on here. It seems like this is a huge step forward. How do you think Quest can impact progress towards therapeutics?
Dr. Valor, seniority?
Wow, that's wide open, and the jury's still out on that, and we're now just starting to look into possibilities of treating peripheral tumors with medications and with cryo and other ablative therapies. So the jury is still out, and I think the possibilities in the future are endless. This is something that's very exciting, and it's pretty much in just the diapers stage. Gus?
Yeah. Whenever I think of Quest, it was one of those things that I was waiting. I was doing all the mental gymnastics, and the company did it for us. They just worked with the great engineers and software developers and everybody there to really embolden us to help the patient the way that the patient is meant to be helped. This is not, I'm gonna feed whenever you have a patient, it's not that you have to make the patient feed your tool. It's all the way around. The tool has to feed the patient. And I do not remember a case that I would have preferred to do with anything else other than MONARCH QUEST. So I can look at referral doctors in the eye or phone calls and say, send it over. We'll get there, we'll put the tool in lesion. If it's something bad, we should know. And if it's something that is non-malignant, I'll follow up. So we are from evaluation to treatment in one physician, either advanced bronchoscopy, interventional pulmonologists, a regular pulmonology that is investing time and resources in learning robotic. It's very fulfilling to be able to do things that others don't. And MONARCH allows you to do that.
Yeah, indeed it does.
Okay, it looks like we have two more, so let's see if we can get these answered. The first is, can you talk about your staff efficiency and how that can be important to your procedural success?
Well, I think Gus has the best. My staff is very good. They're amazing, but I was so impressed when I was over at Grand Rapids with Gus. Go ahead, Gus. You tell them about your crew.
Well, first of all, I have made a couple of friends in your program that probably next time I go, we're going to go out to chat. They're very warm people in your hospital. We brought the lead respiratory therapist to Redwood City whenever MONARCH was a prototype back in 2017. And we brought a respiratory therapist because we knew that these people were going to deploy the equipment, store the equipment, clean the equipment, plan the procedures. And when the respiratory therapists were supported by RTs and not RNs, both are really good, but we have RTs since we started as an airway program 20 years ago. And everybody has a job. Everybody knows how to do everything. Everybody knows how to set the patient up, set up the convene, make sure we can ISO center well, make sure that all the tools are there. They are proud of the platform that we chose. Nobody chose the platform for us. We got our hands on whatever we thought that it was going to be good. And all the RTs are very appreciative of the support of the company, the innovation of the company. And even though they get a little pouty that there's a case that is allocated for an hour and a half, maybe 2 hours, they know that it's so powerful that everybody's going to have lunches. So they are really liking when there's Monarch in the schedule. So I think it's everything. I think that to quote my last Chinese cookie that I had, it says that a chain is only as strong as the weakest link. And I don't think that we have many weaknesses in my program. And I invite you to guys check it out. Just come check me out or check with Dr. Valor. You'll see what it is. A SWAT team deploying against cancer. That's what it is. Everybody has a job and we're really good at it. Last question, Emily, before we go overtime.
Yep, here's the last question. How do you assess the learning curve for MONARCH QUEST, especially for new users or trainees?
Dr. Valor, what do you think? This is a hot topic. Well, I essentially I have to credit J&J. Most of my training was through J&J. They were kind enough to have me go to some seminars and training sessions, and quite frankly, the presence of the representatives at the bedside with me when I started doing the procedures. I mean, when you have an understanding of bronchoscopy, as we all do after being in this for as many years as we have, you know what bronchoscopy. So this is just an additional technology that you're incorporating to what you know already. And I have to tell you, the help and the mentoring that I got from my representatives was amazing. Then I was fortunate enough to be able to spend some time with a couple of other bronchoscopists that were doing this already, including Dr. Cumbo. And that was pivotal to me. That was essentially what pushed me through.
Yeah, well, I don't think that you have to be pushed because you know exactly where you were going. So I think that if anything, we supported, shepherd you to all of those things that maybe we don't know. I think that there's some concepts that are important. The concept of proficiency, the concept of being able to privilege. I think that any robotic program starts with a lot of support from Monarch, from the division. From the time that you get your hands on and see if it's for you, from the time that you do some workshops or you do some cadaver, coming to our meetings in court, going to see a program, it just creeps up on you because you want to feel part of the Monarch family. You want to feel part of the robot that has been in the market forever and is innovating so much and is going to stay in practice for many, many years to come. And you want to feel part of something that is proven success. This is proven success. So what pieces of advice do I have? Try it. Try it. It's going to feel uncomfortable in the beginning. You're going to have doubts on case selection. We mentor you. The company mentors you. KOLs like us, we mentor you. If you believe that you can be better than what you are, Monarch is the way to go. Publications coming up. End of the debate. I really appreciate everybody in the call. I want to say thank you to our AMs, both Maddie and Jake, our RSM, Patterson, Rose. As you can see, we know the names of people that work with us, and we appreciate their work all the way up to Alex and Bridget, and I can keep on going, Jamie and Paul, everybody. We really appreciate you getting the message out there. There's a lot of misinformation, and we are the guys that do it. So any questions, reach out. Remember that the only reason why we do this is patience. Have a good night.
Well, Dustin, you thank the folks that you did. I also want to thank and acknowledge Maddie for being there for me every time, and John and Steve and all those good folks from J&J.
Yeah.
And thank you, Emily, for the great work, and thank you, Bridget.
Yes, thank you both for the very informative talk. We appreciate it. We also appreciate J&J MedTech for being continued SAB sponsors, and everyone who joined. If you have any questions, feel free to reach out and we will get the rest of them answered. Have a great evening. Thank you.
Thank you, guys. Have a good night.